So here's a great case to illustrate why we as ultrasound educators are always harping on people to get multiple views of the heart. And this is a parasternal long axis view. It's a difficult window, but we're able to make out the left ventricle, the mitral valve, left atrium, aortic valve, and aortic root. Here's the right ventricular outflow tract. And we always look posteriorly in this view for pericardial effusion, and we have the descending thoracic aorta here, and really no detectable pericardial effusion. There may be a little bit of fluid versus fat pad up here, but nothing circumferential and really nothing significant to note here. But then turning our attention to the subcostal view, we see that there's significant pathology present. And we have the right atrium collapsed here, the collapsed right ventricle with clear diastolic bowing of the right ventricular free wall. There's a lot of fibrous deposition on the visceral pericardial surface here, and this large echogenic pericardial effusion that's more than 3 centimeters in depth and is something that's causing clear obstruction to flow. Now, one of the things you can check in this scenario, if you're at all wondering if tamponade physiology is present, is to look at the inferior vena cava, because respirophasicity, or movement in the size of the vena cava with respiration, should really be abolished in cases of tamponade. As the pericardial pressure exceeds the right atrial pressure, the IVC just can't empty into the right atrium, and the IVC tends to be relatively plethoric and full. And in this clip obtained on the same date of service by our cardiology consultation, you can see a long axis view of the inferior vena cava and pericardial fluid present here on the subcostal short axis view, and really no respiratory collapse of the vena cava whatsoever. Now, from the prior clip with RV collapse and a large pericardial effusion, it's pretty clear this patient was going to have a rigid IVC that wasn't going to move with respiration. But just one more piece of information for you to take a look at. So keep in mind, multiple cardiac views, really important. This is a patient with a loculated pericardial effusion, and those can be difficult to detect or impossible to detect if you don't take a look from multiple views. So always, in every patient you're echoing, take a look from the parasternal, the subcostal, the apical windows, and put the results of those together and come up with the best picture you can of what's happening.